Assalamu alaikum. My name is Dr. Sinani. I'm an adult neurologist in Riyadh. Today we will be talking about care of the elderly. The outline of today's presentation is to discuss geriatric syndromes, to discuss family caregivers, to discuss organizations and resources in the Kingdom of Saudi Arabia, and to discuss the importance of an individualized care plan for the elderly. The learning outcomes. At the end of this topic, you should be able to describe the factors that need to be considered while planning care for the elderly, recognize the well-being of caregivers, to identify local and community resources available for care of the elderly, and to develop, with inputs from other healthcare professionals, individualized care plans for the elderly patients. So let's talk about the geriatric syndromes and what is the geriatric syndrome. Are they similar to traditional diseases? And we'll give some examples of geriatric syndromes. So if you look at the synergistic interactions of geriatrics with age on the x-axis and organ function on the y-axis, you can see that there's a specific decompensation threshold that is affected by age. So normal aging, our organ functions decline over time. And in patients that have chronic disease, they decline even faster. And when we have a specific acute disorder, our organ functions decline at that time and could pass the decompensation threshold and develop organ dysfunction. If this disease is reversible, that function returns to either the normal level or a level below that. And you can see that in the elderly population, that the level of decompensation is significantly affected. Now we'll discuss geriatric syndromes, where there's no discrete disease or syndrome. What we understand with disease processes is that there is a known etiology with a known pathogenesis that presents with a known but variable presentation. Whereas in geriatric syndromes, there is an unknown pathology associated with an unknown pathogenesis that presents with a defined set of signs or symptoms. An example of this would be delirium, where a urinary tract infection or a pneumonia can present with delirium. And the geriatric symptoms are multiple, where multiple etiological factors can present with interacting physiological pathways into a single symptom. So the definition of geriatric syndrome is a multifactorial health condition that occurs when the accumulated effects of impairments and multiple symptoms render an older person vulnerable to situational changes. And specific known geriatric syndromes include delirium, dementia, malnutrition, polypharmacy, incontinence, frailty, depression, falls and post-falls, and sarcopenia. The unified conceptual model of geriatric syndrome include having multiple shared risk factors, including diabetes and hypertension, multiple syndromes which include incontinence, falls, pressure ulcers, delirium, and functional decline, associated possibly with frailty, would lead to poorer outcomes that can send the patient to a nursing home or to his demise. The shared risk factors include diabetes, hypoglycemia, sensory decline, mobility related to aging, and hypertension and risk of postural hypertension related to antihypertensive drugs. Factors that need to be considered in this clinical case: a 67-year-old woman complains of poor sleep and decreased appetite. She lives alone and has been a widow for the past year. She's recently been given propranolol for hypertension, and her comprehensive geriatric assessment shows a depression score of 11/15, a mini mental status examination of 27/30. Her ADL examination shows that she's independent for activities of daily living, and her nutritional assessment score is 6/14. There are many social factors also to be considered, with the patient's loneliness and beta blockers attributing to her depression, which could lead to decreased appetite and depression. There are many determinants of active aging, including the economic determinants, health and social services, behavioral, personal determinants, physical environment, and social determinants. All are part of the active aging process. In summary, geriatric symptoms are not part of the traditional disease model, and specific factors influencing aging should be considered while planning for care of the elderly, such as culture, abuse, loneliness, poverty, and discrimination. Disease management model is very different, so the care management model should be adopted appropriately. We'll switch now to family and caregivers. And one question that we have to ask is, why don't people call themselves family caregivers in Saudi Arabia? Why is there an increasing interest in family caregivers? And how do family caregivers help the elderly? And what do family caregivers need? So when you look at caregivers classification, they're generally divided into formal and informal, while the formal ones are usually paid professionals, and the informal ones are usually unpaid family members. Family caregiving is broadly defined and refers to a wide range of unpaid care provided in response to illness or functional impairment to a chronically ill or functionally impaired older family member, partner, friend, or neighbor that exceeds the support usually provided in family relationships. When we look at specificities of family caregivers in Saudi Arabia, Muslim people feel caregiver is naturally expected from them from the cultural and spiritual concerns. There are many social changes on availability of the caregivers, as many family members in Saudi Arabia have dispersed geographic availability. The long-term care facilities in Saudi Arabia are generally lacking. There are many types of care provided for the elderly, including activities of daily living, instrumental activities of daily living, supervision and management of medical bills and records, assistive devices, carrying out routine medical procedures, providing emotional support and well-being for the elderly, and arranging for their medical visits. We will talk about the impacts of the caregivers that must be addressed in Saudi Arabia. They have many medical and psychological problems. They could be emotionally stressed and develop their caregiver burden. There's many leisure and social activities that many caregivers do not take time for themselves, which can lead to isolation, fatigue, frustration, and a sense of hopelessness, where caregiver burnout or elder abuse could exist. The financial burden for the caregivers must also be considered. There is significant importance in supporting family caregivers in assisting the elderly. Information, skill building, education, and training must be addressed. Case management must be associated with their care. Counseling and emotional support and well-being of the caregivers must be addressed. They should also have breaks from caring for their elderly, whether hours or days, and they should also be addressed with respect to their financial support. When we discuss about caregiver and care receiver, many times support and services to caregivers is based more on the characteristic of the recipient rather than on the caregiver's situation and his needs. The needs should be addressed specifically for each caregiver. Family caregivers' well-being is important to care recipient health. In conclusion, there's many stressors that should be addressed and appraised for the caregiver, both with respect to social support, breaks, formal services, and self-esteem, to look at the burden of the caregiver and to improve his or her well-being. Social support is strongly related to well-being, but unrelated to burden. When you look at organization and resources in the Kingdom of Saudi Arabia, care of the elderly in Saudi Arabia, the unmet needs, where care of the elderly is given in Saudi Arabia, what do we mean by integrated network for elderly care? So when you look at the amount or burden of the elderly in the Saudi population, in the 1950s, the amount of elderly was very little. And in 2010, the pyramid has flattened on the bottom. And we expect by 2015 that 18% of the population by 2050 would be above the age of 65. The requirements for care of the elderly are multifactorial and include primary care, secondary care, and social and nursing care. Primary care mainly includes general practitioner care in primary healthcare settings, which should include physical therapy, audiology, and others that can be done in the primary care setting. Secondary care settings, there are many planned and unplanned admissions to hospital, and rehabilitation is sometimes needed for the elderly. There are many social and nursing care issues, including home health care issues, nursing, and residential homes. When we look at geriatric resources in the kingdom, there is the National Committee for Elderly Care under the Ministry of Health, which are mainly in the primary health care centers. There are some geriatric units and memory disorder clinics in some hospitals. And there are some long-term facilities, but not specifically for the elderly. There are many resources, including associations for patients like the Saudi Alzheimer's Disease Association, charity centers for the elderly care like Sehat Charity for Social Services in Dammam, and hospital care that is not specific for the elderly. When we look at integrated networks for services designed for intervention, we see that elderly, there's a strong relationship between the home, the hospital, the general practitioner, community geriatric evaluation units, and the case manager. And if patients are eligible for this service, generally a care plan should be done, which includes the general practitioner, the case manager, the community geriatric evaluation unit, and these include home care, day hospital, hospital at home, or nursing home care. The integrated network of elderly care could be very complex, but includes geriatric mobile teams, consultations in a comprehensive geriatric assessment, emergency room consultations where advice from the geriatric mobile team is important. Acute geriatric units can be very beneficial for patients rather than the general medical ward. Acute medical or surgical units, day hospitals, a memory clinic, rehabilitation. In summary, care of the elderly in Saudi Arabia, despite its increasing importance, is not yet well organized. There is lack of defined resources available for the care of the elderly. Care of the elderly needs an integrated network of services. All elderly patients need an individualized care plan, and we will discuss this plan and how to achieve it, how to implement such a plan, and we will discuss a clinical case. An action plan for the elderly is needed in situations of frailty or comorbidities and requires a formal collaboration between many healthcare professionals. And the aim is to better coordinate between local health and social stakeholders, and a multidisciplinary team should be provided to result in more efficient care pathways for these patients. Key points to achieve this plan include appoint a coordinator to coordinate the activities, identify specific problem situations on the basis of the overall assessment of the situation, looking at the medical, psychological, social aspects of the patient, to prioritize situations where intervention is both necessary and possible, to collect and consider the preferences and expectations of the patient, and to negotiate common goals with the patient. We should plan an intervention to achieve these objectives, designate professionals responsible for the implementation of each intervention, determine the criteria to establish the process and outcomes, set dates for reviewing interventions, and organize alert procedures in case of intercurrent problems. This is an example of a case where a 74-year-old woman presents to your clinic for the first time following the retirement of her general practitioner. Her medical records show consultations and results of laboratory analysis, but does not appear observation or monitoring her treatment. There is a history of depression, hypertension, bilateral cataracts, surgery, bilateral knee osteoarthritis, a left knee prosthesis, and she had 3 normal deliveries. She's a widow and lives alone. She has 2 children that live outside, and her daughter helps her 2 times per week. Her last medication list include atenolol, 100 milligrams per day, valsartan and hydrochlorothiazide once daily, paracetamol 1 gram up to 3 tablets per day, zopiclone 7.5 milligrams at bed, bromazepam, a quarter of a tablet in the morning and half a tablet in the evening, and haloperidol at night. You query the patient about haloperidol since you do not understand the indication, and she says that it's probably for her sleep disorder. So you decide to stop bromazepam and haloperidol. In the second visit, she can no longer sleep at night because she sees persons in her apartment. She thinks she might be going crazy and is too frightened to explain her symptoms to her daughter. You decide to organize monitoring at home to better assess her situation. During your home visit, you find that the home is clean and tidy. You call her daughter, and her suspects memory loss and reports some falls in the last year, and informs you that she is unable to take her mother to house. You decide to organize a geriatric psychiatric follow-up and take an appointment with psychiatry. 2 months later, psychiatrist has established a neuroleptic treatment, but there has been no medical social assessment of the patient. You take an appointment for geriatric assessment, which takes place in 4 months. 3 months later, her daughter informs you that her mother suffered many falls and she is no longer taking neuroleptics because of intolerance. The patient hands you referral for a geriatrician, but does not understand the benefit of the consultation. An individual care plan is urgently needed. Urgent issues that need to be addressed include stabilizing the patient's mental status in addressing her hallucinations and depressive symptoms, and to better define her diagnosis, whether her psychiatric condition is neurological or psychiatric. You doubt the associated cognitive impairment and consider cognitive assessment once psychiatric condition is stabilized. Her falls must be addressed and iatrogenic effects of the drugs must be considered, and we must monitor the compliance of her medication, and we must address her specific isolation at home. So an integrated care plan would look something like this, where we have the problems addressed from 1 to 6, with psychiatric being the first priority, medications, patient understanding her situation, cognitive effects must be addressed, the functional decline and falls must be addressed, isolation and security, specific objectives are made, responsible people are addressed, and criteria for achieving each individual goal is described. And goals are set as short-term and long-term, depending on the priority of each condition. And you should be the orchestrator of all of these priorities. The summary of the lecture shows that the geriatric syndromes are not part of the traditional disease model, that there is significant interest in enabling family caregivers to sustain their roles and maintain the elderly in the community. There is lack of identified geriatric availability for care of the elderly in Saudi Arabia, and an individual care plan is encouraged to support for multidisciplinary teams in a non-hierarchical framework for cooperation. The take-home message of today's lecture includes that the disease management model is different in the elderly, so care management model should be adapted specifically for each patient. Managing the emotional and psychological stress is needed in order to reduce negative effects of burden of family caregivers. Care of the elderly need an integrated network of service, and an individualized care plan is imperative to improve coordination between local health and social stakeholders for a more efficient care pathway. Thank you very much for listening.